All right, welcome everyone. I'm just going to say a few words of greeting here and point out to you that this is a first of a kind event in many respects. It's one of the first times, maybe the first time, where all of us from the system are coming together, both as full-time and voluntary faculty, and learning about how to be more effective teachers. And that's a first in its own right as well in GI here. Teaching is maybe the most important thing that we do on a day-to-day basis. Sure, we see patients, and that's very important. Some of us do research, but I happen to believe that there's nothing more important that we do than teach the next generation of gastroenterologists. So I'm very grateful to Brijen Shah, who conceived of this program and pulled it all together. And of course, you'll notice from the terrific faculty that we have here that we're blessed with a wealth of really excellent teachers in the clinic and in endoscopy. For example, I think David Sacker is going to be teaching Jerry Way how to do endoscopy. No? How to teach it. Well, he is a master educator. We'll see. Anyhow, I'll cut the comment short, but with a note of great appreciation for Brijen and for all the faculty who are participating in this Teaching the Teacher event. We'll get it going now. So thanks to Brijen.
Thank you very much for that nice introduction, and I'm really excited that so many people came. We didn't know what we were going to expect, but it's really exciting to see people from all over. I think that if our fellows knew that you were taking this much time to take time out of your lives to do something that makes their experience better, I think they would be really moved and touched too. And I think one of the reasons why we're all doing what we do is because teaching is a core part of our job and what we really love and value. So I hope that this evening provides some useful information. I by no means am not here to tell you how to do this because I don't know how to do it all. But we kind of organized the program in three parts. One, to give you some updates about GI fellowship training. So for those of you that don't live and breathe education, there's a lot of stuff that's changed probably since you trained as a fellow, and I think understanding what that is from a national perspective will help you understand how to become a more effective and better teacher. And then we're going to spend the bulk of the time really thinking about how do we become better teachers around endoscopy. And then lastly, how do we become better, more effective, and more engaging teachers in the clinic and at the bedside. So you guys have already seen the agenda. Lots of wonderful people are going to take part in this, and you can see who those folks are. And all the material that's electronic, we're going to make available to you at the end, so you can look at it, download it, print it out to use how you see fit. And the things we tried to hand out to you, I'm going to go over in a moment, but they're really meant to be practical tools that you can take back with you. So really my goals for the evening are, one, for you to appreciate the changes in training. Two, through those topics that I mentioned, to provide you tips with how to be a better teacher, all with the eye towards and in the context of how do we also get better assessment. And you'll see why assessment has become more important now than in the past. And through that, we'll familiarize you with some assessment tools that maybe some of you are currently using in your programs, or maybe you've seen and would like to try to employ, and we really encourage that. And so we're going to talk about what those tools are, and then a chance for you to meet one another and network with one another. There's a few things. So the first page is an evaluation. So please tonight, before you leave, fill this out, drop it off in the corner. It'd be very helpful for us to know, one, what you thought of the program, but two, to get your ideas about other faculty development topics that we can think about doing and putting into either grand rounds or doing events like this. The rest of the material we'll go through as the evening goes on. One is just a resource guide of websites to help you with your teaching, some of which we're going to talk about over the course of the evening. You have an example of some new tools in the GI curriculum, which I'll go over in a moment. At the very end, you have copies of 2 validated endoscopic assessment tools that Dr. Way and Dr. DeMeo will talk about in a moment. So with that, I'm going to turn our attention very quickly to updates in GI fellowship training. So there's a few big things that you need to know about. So number one, we are a 3-year fellowship. I think many of you know that, although some of you trained at a time when it was a 2-year fellowship. That's not going to change. That was definitely part of the prior system. The older way we used to do things was very much based on faculty assessment. So it was people sitting around a table, sitting around a room together and saying, is this person progressing? Are they not? But the metrics of what that weren't so clear. It was kind of like you knew when they were good and you knew when they were bad, but we didn't really consciously think about what that meant. And this was true in all of graduate medical education, not just GI fellowship. It was true in residencies. It was true in other fellowships. And it was a very knowledge and procedure-based training program. So you had metrics for how many things you had to do by the time you were done, and then you sat for a high-stakes exam, which was the board exam. If those two things worked, you moved on. We realized that in graduate medical education, that mantra or that mentality was really failing the healthcare system, because there's a lot more competencies and skills that one needs in order to really function in our healthcare system today. And programs used to only be assessed about every 3 to 5 years. And so they would get a visit from the ACGME, which is the accrediting body. They'd come visit us as a program, and they would give us they'd say, yay, nay, here's what you can do better, and then they would leave us alone, hopefully, for 5 years. So the new things that have changed, in a sort of at the 30,000-foot view, are that we have to use milestones, which I'm going to explain to you what those are, but basically very descriptive language that encompasses all the knowledge, attitudes, and skills that we want fellows to graduate with. And this is not only for fellows, but similar types of things are being used in residencies. These milestones get reported by the program every 6 months on every fellow in an anonymous way. And the fellows obviously see this data, but this goes up to the ACGME. So they want to see how our fellows are progressing against everyone else in the country. The language in these milestones, as we'll talk about, really describes the behavior and the things we want them to know, see, and do. In GI, the liver biopsy requirement has been removed, so that's no longer a requirement to graduate for fellowship. And there's a greater incorporation of things such as scholarship, which is defined fairly broadly, but that has classically been research, but it can include quality improvement or writing case reports. And then there's also increasing emphasis on quality and patient safety. So how are our fellows engaged in doing things around quality and patient safety? And lastly, there's a greater oversight of the quality of the program by the institution. So not only is the ACGME interested in how things go, but our own GME office now has greater responsibility in making sure that our program quality is pretty high. Because if our programs start to suffer, our institutional accreditation might suffer. So that's how things have changed. The institution looks at our program quality using some outcomes and some metrics, which are listed here. Primarily, they look at the board pass rate, which is over a rolling 3-year average. They look at the resident faculty survey. So many of you have completed the resident faculty survey. It asks you between 18 and 20 questions. We do this every year. And it also looks at resident and faculty scholarship. So scholarship is defined as anything that results in a publication or a presentation. And we have to report that up to the ACGME, both for the residents and for the faculty. And the way that Dr. Lightman and Dr. Barnett and the GME office have kind of rolled this data up for Dean Charney has been to create a dashboard. And these are the things that go into the dashboard, and then they score our programs on a percentage of points. I share this information with you only so that you know that these are the different things that go into people looking at us and saying, you've got a great training program or you've got a training program with a problem. And teaching and feedback are a big piece of this, because if you've done these surveys, there's a lot of questions about, what's the quality of the teaching? Do the faculty care about my teaching and learning? Do I get feedback? Do I get evaluations? So there's a lot of elements of that, which is why we want to spend time on this part of what we do every day with our fellows. This is an example of what a milestone looks like. It is a generic milestone for all the 22 specialties within internal medicine. So these are not GI specific, these are for all of internal medicine, and you have to understand them within the context of your specialty. And how these are organized is it has the domain up here. So for patient care, this is being able to be a consultant. And it's a development trajectory, kind of based on Dreyfus, who wrote about becoming, a novice, competent, and becoming an expert. So you can be critically deficient in an area. So critical deficiency is, somebody who's unresponsive to questions or concerns of others when acting as a consultant, or unwilling to utilize consultant services when appropriate for patient care. All the way up to ready for unsupervised practice, which is where we want people to get by the time they finish. And then there's some language about what's an aspirational person. So this is somebody who's been in practice 5 or 10 years, is quite good at their craft. But it lets people know where we kind of want them to be, even once they go into practice. And we sort of figure out through evaluations and through clinical competency committees, which is a group of people who gets together to look at all the data to determine where along this trajectory the fellows are. So that's the generic stuff that we have to do for the ACGME. So within GI, the 4 specialty societies got together and said, there's a big problem. The generic language isn't going to work for the everyday clinician educator, right? I can't give you some blanket language and you have to sort of figure out what does that mean for a gastroenterologist. So the other way to think about that is something called an EPA. So it stands for Entrustable Professional Activity. So it's basically like if I polled another physician that's not a gastroenterologist, or I took a patient and I said, tell me, what does a GI doctor do? What's their scope of practice? What should they do? It breaks down what they do into tasks that people understand, right? So we do endoscopy, we perform colon cancer screening, we treat dyspepsia, we order medications for IBD. So these are like discrete tasks. And the reason why people like that way of thinking about things, it's very like workplace based. If I tell you, you need to, by the end of training, be able to perform a competent colonoscopy for colon cancer screening, you get what that means. Versus if I say you need to competently perform invasive procedures and interpret the results. I mean, you have to extrapolate what that means for your field. So this is one reason why the 4 GI societies moved to creating a set of EPAs for the profession. The other reason is because people used to always create a curriculum, and they were like, here's your curriculum for what you need to learn. The problem with the curricula are that they are defined based solely on knowledge, and they don't really look at what the health system needs. So about 5 or 6 years ago, medical educators started saying, we really need to look and see what does our system need and require of our physicians, and build the learning backwards. So what are the competencies they need, what are the pieces of knowledge they need, and then make sure that we provide those experiences in training so that they can go out and do those things. That's really a big push of what MedPAC, who's part of, they're sort of deemed through CMS to be involved in GME as well as many other things. They're looking at in terms of program quality. GME nationally as a budget item is over a $9 billion budget item. It has faced a lot of scrutiny in the last 3 or 4 years in Congress. People are looking to find ways to cut the budget, and they think that the program quality nationally is suffering. So this is why a lot of attention has been paid to this in the last couple years. So I told you a little about EPAs. When you read these, and I'm going to go through an example of one, you'll see things about the knowledge, attitudes, and skills you need. They should be acquired through training and recognizable. They should be things you can measure and observe. So these are things that you can assess. And finally, when you look at the EPAs together, they constitute the profession. So when you read them all together, you should say, yeah, that's what a gastroenterologist does. So here are the list of the EPAs. Actually, we had 5 GI societies that came together. I apologize to the folks in motility who I forgot. And these are all the people from across the country who came together to do this. Many of you will recognize lots of those names. And the EPAs were divided up by topic using the expertise of the folks in the specialties. So like ASGE did the endoscopy and the biliary and the pancreas ones. ANMS did the functional bowel disorders, motility, and GERD. The ACG and AGA collaborated on some of the other ones that kind of cut across a lot of different practices. So we used the existing GI core curriculum. We looked at what people do every day in practice. And then we integrated things like radiology path, quality, practice management, and special populations into all of that. So when you read these, that's what you'll sort of see encompassed into that. And how these work, and if you want to see a copy of one, the total list is on this paper. So there's the 13 EPAs are listed there for you with a brief description of what the EPA covers. And then if you actually want to see an EPA, I photocopied for you the endoscopy EPA, since we're going to spend a lot of time talking about endoscopy. That's what's on the blue page. And it starts with the EPA title, followed by what the description of the EPA is. And then the bullet points are broken up in terms of knowledge. So what do you need to know? What are the skills? And then what are the attitudes? And so the attitude piece is really where you find out, there's some of the professionalism stuff is in there, some of the things about understanding special populations. So you'll see a lot of the women's health, the geriatrics piece is put in there. The things around practice management, quality, improvement, and patient safety are also incorporated into each of the EPAs as the task requires. So you'll see in the endoscopy EPA, there are things that relate to adequacy of bowel prep and sedation and follow-up. Then, if you continue down, it links these to the ACGME core competencies. And then finally, it breaks it up into how they fall back to the reporting milestones. So probably for most of you, the stuff after the the first 3 boxes is probably more than enough detail. But if you're curious, it's all there for you. And then it also talks about ways that we can evaluate these based on the tools that exist in the literature. So when you hear from your program directors that we want you to use this tool or the other, usually it's informed by things like this that say, we know that they work. And the other thing I say, since I see we have lots of our PEDS folks here, a lot of the reason why we chose this was because PEDS had already created some EPAs within their fellowship and their residency, and it worked really well for them. So we asked folks from Nash Began to come and consult on when we were putting these together. So I think that it's nice that there's some synergy between the different GI societies in that regard. The last piece is we wrote about implications for the trainee. In a perfect world where we didn't have to worry about documentation and regulation, once somebody has achieved the ability to do a task, we should stop having to supervise them. So, in theory, if I know that a fellow can take a history and do a physical exam and write a note and a plan in the clinic, in a perfect world, I wouldn't have to sit there and go back and supervise them. But that's not how things work. So we do realize that people, as they grow, need to be able to have some graded responsibility so that when they show up on day one of their job, they're not just left totally alone. They've had some independence as they grow. So in each of these EPAs, we tried to create language that would give ideas for entrustment. A lot of that's around teaching or being a supervisor or being a more senior fellow, teaching a more junior fellow with supervision. Those are different ways that happens. If you want to see all of these electronically, just go to this website. All of this documentation, all of these are downloadable. You can modify them. They're PDF documents with fillable forms. You can convert them into Word documents and use them for your own fellowship. There's a list of the EPAs. So what should you do with this information? So number one, if you work in a particular area, you do mostly outpatient, you do motility, you do IBD, read the EPA at least for your area. Why? Because it will tell you what you need to teach. It should also tell you what skills you should be watching for when you're taking care of patients with that fellow in that arena. And then think about how you can incorporate some assessment. If you're going to give a talk this year, so if you're going to give a fellows conference or you're going to give a talk where there's going to be trainees, go back to this document to see what should inform your talk so you can know what people need to learn. And lastly, you can use this to help stimulate further reading in your learners. So if you sit down with a fellow, I envision that maybe what we'll do one day on our IBD service is to sit down with our fellows and have them look at this at the beginning of their IBD rotation and say, tell me, what areas of the knowledge part do you feel comfortable with? What areas do we need to work on? And then I, as the attending, can say, here's places you can go to read to further your knowledge in that area. Those are ways that you can hopefully use this tool. And then lastly, just my plea for more ongoing and specific feedback to people. It's not the focus of what we're going to talk about tonight in total, but we can in the future. The EPA language and the milestones help to give you the language if you have a hard time coming up with that. So I really like it. Like, we've used the language within the professionalism milestone to help us sit down and give some feedback around professionalism with some of our fellows. And it just makes it easier because it says, look, this is what we expect of you, and here's what we heard. The two are sort of a disconnect. You're kind of here, I need you to get here. How can we get you from point A to point B in this area? And if you're on your CCC, continue to participate. If you're not, the CCCs at each of these programs rely on your observations and your honest and candid feedback to help do the work of making our fellows better and ready for when they leave so that they're fantastic physicians. So that's all I have to say. Any questions for me? All right. Either I've bored you or I've confused you. But in any case, I'm here if you have questions. I'm going to turn it over to Dr. Way and Dr. DeMeo. I think Chris is going to speak first on upper endoscopy, and then Dr. Way will speak about colonoscopy.